All right. This is a brand new screen to our 340B presentation, and what it represents is all the gray areas in 340B. It has been changing dramatically in just the last few weeks. HRSA has come out with what they refer to as their omni guidance or mega guidance, something we've been waiting on for 2 years, trying to clear up some of the gray areas. And they have done that, and they've created some new ones. So there's a lot of changes in 340B that just came about. We're kind of waiting to see which ones get approved and which ones get changed again. If you currently have a 340B program running, there's some dramatic changes, and we should probably talk about them on a separate call. So keep that in mind, that things are changing dramatically, and 340B is evolving as we expected. But let's jump in and do kind of an intro to 340B. The 340B program is an unintended consequence of the Medicaid rebate program that was started in the late 80s and early 90s. The 340B was put into place because a lot of hospitals, when the Medicaid rebate program got put into place, lost their abilities to buy dramatically discounted drugs. So they put 340B in so those certain safety net hospitals could purchase drugs at that discount again. Provides a discount on outpatient drugs, so keep in mind that as we talk about this, we're always talking about outpatient drugs, whether it's outpatient usage in your facility or outpatient at a local pharmacy. Average savings is 25 to 50%. The two pillars of 340B, one being getting discounted drugs to the indigent or self-insured population. The other one is helping a hospital to expand, a hospital or clinic, to expand and provide additional services to all their patients. As an administrator of a hospital, you know if you want to expand or provide more of anything, you need revenue to do it. So part of 340B, one of the pillars of 340B, provides revenue to your facility to expand and help all patients. Manufacturers that participate in Medicaid must also offer a corresponding 340B discount. The program is overseen by HRSA and OPA. They're both subsets of Health and Human Services. Prior to 2010, if you looked at 340B, it was probably not a program that was would have made sense for most critical access sole community facilities. 2010, there was a dramatic change. They took away the financial burden of starting your own pharmacy, building, staffing, stocking your own pharmacy, and then also the inventory burden of having two totally separate inventories. Prior to 2010, either a hospital pharmacy or what we call a contract pharmacy, that's a pharmacy in your community, had to have two totally separate inventories. And we still run into this today where pharmacists don't want to participate because they don't want to have two inventories. That's been changed. Now it's called a virtual inventory. Everything is accounted for in individual pill bottles. Program requirements, who can participate? There's a lot of other eligible areas of participation like Ryan White and various places, but for our talk today, we're going to talk about DISH, critical access, sole community, rural referral centers, freestanding cancer clinics. If you are one of these, the requirements are very simple to participate in the program. You must, as a DISH facility, you must have a greater than 11.75 disproportionate share. Critical access, all you need to be is a critical access hospital, either county-owned or with a contract to provide services to a governmental entity, whether it be a city, county, or state government. 340B program has a lot of moving parts. If your facility has child sites, each one of those child sites has to be registered with OPA, Office of Pharmacy Affairs. Each one of those pharmacies that associates with your hospital has to have a contract with your hospital, and each one of those pharmacies is going to require a wholesaler attached to that. So if you have a hospital and multiple child sites, It can be a tangled web of agreements to get the 340B program up and running. ACI comes in and does the data analysis, patient eligibility, and pharmacy arrangements for you. There's two sides to 340B, and this is one of the areas that's going to be changing in the upcoming year with the new mega guidance from HRSA. Split bill, or the in-facility use of outpatient drugs, and the term split bill comes from, imagine somebody comes into your ER. While they're in your ER, those are outpatient drugs. As soon as they're admitted, or if they're admitted as an inpatient, as soon as they cross that threshold to become an inpatient, you must split that bill into ER outpatient and then inpatient. All the drugs used in the ER are eligible for 340B. All the drugs as an inpatient are not. So we need to split the bill. On split bill, the purchases of those drugs are at a significant discount. If you have a cancer clinic or an infusion clinic or an extremely robust ER, then split bill makes sense. For most critical access, sole community hospitals, it's tough to get a split bill program to make sense, to be worth the effort, which is more of the burden than the finance, but also to get a return on investment for the investment in the split bill software and the getting the program up and running. The other side, the one we'll focus on today, is contract pharmacy, partnering with a local pharmacy to capture 340B savings. Where does that savings come from? I use Lipitor as an example. If one of your patients goes to a local pharmacy and is prescribed Lipitor, that pharmacy is going to bill their insurance company, is going to bill the patient's insurance company the network price, which is right around $139 for Lipitor. Under 340B, we still bill that entire $139 to that insurance company, or the pharmacy bills that to the insurance company. But our cost for that transaction is only $88. After drug acquisition cost, dispensing fee, and admin fee, we've spent $88. We've billed the third-party payer for $139, leaving $51 in savings or revenue available to the hospital. This is what would have normally gone back to the drug manufacturer. So the drug manufacturer is the one supporting 340B. They're giving up a portion of their profits to help support safety net hospitals. And as 340B has grown, that's where a lot of the controversy in 340B has come from. Actual numbers, this is a client that we have up and running. These are numbers that were just pulled down and added to this. These are last month's numbers. This hospital has 4 pharmacies, 3 pretend names and a Walmart, but you can see the various pharmacies down here all producing $20,000 to $30,000 a month. The total produced for this hospital has been 80, 90, 87, 100. Across the board, this hospital will do very well this year on 340B. And this is not some anomaly hospital. This is a critical access hospital in a rural community. I think they have about 20 to 25 doctors. So it's a very normal situation. How is the savings margin captured? This is an example of how a pharmacy is currently doing transactions today. One of your patients goes to the pharmacy, has a $20 copay. That pharmacy bills the PBM or the insurance company for the remaining $80 of a $100 prescription. They may have purchased that drug for less than they sold it for, so they made a profit margin, and their dispensing fee was $5. They take the remaining $89, send it back to their wholesaler, refill their pill bottle, and they try and do that as many times a year as possible because that's how they make their profit. On 340B, we make a small change. Same copay, Same $80 coming from the third-party payer, same $100 in the pharmacy's checkbook. Nothing changes up front for a pharmacy on a 340B transaction. In most cases, with most chains, they have no clue 340B is even going on. There's no software. They do nothing in regards to 340B at the pharmacy. The change comes in the replenishment. Because now we are going to replenish those drugs, we're going to give those drugs back to that pharmacy. They've lost their ability to make a profit margin on them. They can no longer buy them for less and sell them for more. So we have to compensate them for that by giving them an enhanced dispensing fee. So where they were making $11, which is kind of the national average for an independent pharmacy in America today, is about $11, we're going to increase their dispensing fee to $15. This is one of many different models that's available in 340B. It's just the simplest one to explain. So they're going to make $15 instead of $11. That's why pharmacies want to do it. They are more profitable under 340B. The third-party administrator, the administrator that sorts the claims, is going to make $5 per claim, and these are just average numbers. That's actually coming down quite a bit in recent time. The program is becoming more efficient as it goes along. The hospital is going to make $80 out of that $100. So we spent $15 on a pharmacy, $5 on admin, $80 goes to the hospital. But now you have to replace the drugs on that pharmacy's shelf because you can buy them so cheap. Now you spend $40 to replace his drugs. Now he's made 15. His drugs are back on his shelf. He wants to do that as many times a year as possible. You've collected 80, spent 40. $40 is the net benefit to the hospital. And that's just a very general example of the way 340B works. How do we do all that? Your hospital will set up an ADT feed or an encounter feed that'll go to the 340B TPA. They'll collect every patient that walks through your doors, inpatient, outpatient, clinic visit, ER, whatever you see a patient for, we want in their servers. As they're collecting your data, they're monitoring your pharmacies. Every time your pharmacy fills a prescription, whether it's yours or not, they send it through a thing called the switch. The switch is a hub that sorts those prescriptions and sends them to the correct insurance company, whether it be Medicaid, Medicare, Blue Cross, Blue Shield, whoever. There's an identifier on every prescription so that it goes to the correct payer. While that's happening, while those prescriptions are going out through the switch, we're going to pick up a switch data relay to the TPA. Now they're going to have all your encounter data, all of the prescriptions going through your pharmacy, and they're going to look for a 340B eligible match. A patient that has been seen by one of your physicians at an eligible location and filling at your contracted pharmacy. Once we do that, and we're going to kind of track that same claim we had up above, that $100 claim, and we're gonna track one claim. Of course, that's not the way they do it. They do it on mass billings, either twice or once a month, depending on the administrator. But we've identified a claim, that $100 claim. So we bill the pharmacy for $85. Pharmacy's getting paid $15. They're the first one to get paid. Bill them $85. They remit $85 back to the TPA. A PO is sent to the wholesaler to refill their pill bottle. $80 in margin comes back to the hospital. TPA held on to $5. The invoice for the drugs comes to the hospital. The replenishment goes to the pharmacy. At no time is the hospital stocking drugs on the pharmacy shelves. The pharmacy has, in essence, fronted their drugs to you. They've loaned their drugs to you, just like they do to an insurance company, until they're paid for them. So they've fronted their drugs to you, and you're replacing their drugs. So as soon as the drugs go on the truck at the wholesaler, they become the property of the pharmacy. So you don't have to track those drugs. You don't have to worry about compliance at the pharmacy. They belong to the pharmacy. Wholesaler invoice comes to you. You pay the invoice. You have $80 in your account, pay the $40 invoice, the margin remains with you. Issues and questions on 340B. Drug ownership, I already touched on. Replenishment versus stocking. We're replenishing the drugs that are used off the pharmacy shelf, and you are not stocking drugs at their pharmacy. It is a bill to, ship to relationship. Bill comes to you, drugs go to them. You don't have to touch those drugs. You don't have to have anybody at your hospital deliver drugs to a pharmacy. Replenishment on package size or unit size. We, under OPA guidelines, we have to replenish on the exact same NDC 11. That's the drug code, the national drug code, all the way down to package size. If that pharmacy is pulling drugs out of a 100-count pill bottle, we have to send them a 100-count pill bottle. If they're pulling them out of a 1,000-count pill bottle, we have to send them a 1,000-count pill bottle. So tracking that is what the virtual inventory is for. You send patients over to the pharmacy, they use 30, 60, 90, 120 pills out of a 100-count pill bottle. We now owe a package to that pharmacy. Keeping the pharmacy whole, especially in rural environments, is extremely important because you're dealing with independent pharmacies in a lot of cases. Walmarts and Kroger's, Dillon's, Walgreens, not too worried about their business model. They do very well on 340B and they're happy with it. We spend a lot of time making sure that independent pharmacies and small regional chains don't get hurt by 340B because it's very easy if it's not set up correctly. A couple issues that they have to deal with. True up. We've got that 100-count pill bottle. We've used 30, 60 pills out of it, but then we don't use any more. So in essence, you owe that pharmacy 60 pills. At the end of a true-up period, which is set up prior to the program going live, we define after a certain period of time, we will make you whole. Those claims are reversed out. That revenue is given back to the pharmacy and goes back on their retail book of business. Some administrators stretch that out to 180 days, which is very hard on an independent pharmacy. We try and make it 90 days. Even worse than that is out-of-stock drugs. If you do owe them a package, you've hit 30, 60, 90, 120 pills, you owe them a 100-pill package, but their wholesaler is out of stock. He can't just sit there and wait until he gets those drugs. He has to substitute it for something else. We can't. So he's now owed a package of drugs, has substituted it. So financially, he's taken a hit here. And if we don't get this turned around relatively quickly, it can cause him issues. So we like to set up our out-of-stock replacement at 30 days. We try and order it 12 times, 3 times a week for 4 weeks. If we can't get it, we give that inventory back to him because he's probably already substituted it for something else. And then change to NDC 11s. Anytime an NDC 11 is changed, we can no longer get that drug. We reverse those claims and get them back to the pharmacy. Pharmacy volume. In a rural environment, this is key. If a pharmacy isn't moving enough prescriptions through their inventory, it'll be the program will be very difficult for them to deal with because we'll be dealing with true up constantly. There'll be no revenue in it for the pharmacy yet, or excuse me, for the hospital, yet you'll be paying a TPA to process all those claims. All of a sudden, you have a negative 340B program. We've been called in multiple times in the last year to help hospitals clean up their program because they were losing money on certain pharmacies. And Walmarts are very easy to do that with if you use the wrong administrator. So pharmacy volume and knowing whether that program is going to be profitable is key, especially in a rural environment. Challenges on the program. For the pharmacy, they have to worry about ordering and inventory swell. The one thing the pharmacy kind of relies on is his ability to manage his inventory. And on 340B, you're going to come in and change his inventory management because now you're going to be ordering drugs for him. And making that so that it's an easy system for him is ideal. The The TPA that you choose will be extremely important. Some of them do not do well on the ordering side. Good example is if a pharmacy sells 10 bottles of XYZ prescription in a day, the next day he wants 10 more coming in from his wholesaler. If he goes in, orders 10 off his retail account, but we've got 340B running and you've used 4 pill bottles, so we order 4 for him, all of a sudden next day 14 shows up. That's where inventory swell starts, and that's a lot of the bad PR in 340B for small pharmacies has been in inventory swell. So choosing the correct TPA and working with that pharmacy is key. We regularly unravel issues with small pharmacies where they've allowed their program to get out of control. It can be very damaging to them and very damaging to you. So making sure that that pharmacy is running correctly is key in 340B. Like I said, Walmart and Walgreens we're not too worried about. But when it comes to small regional chains and independents, 340B can be very dangerous for them if it's not set up, priced, and managed correctly. Benefits. 340B discount for uninsured patients. As I said, one of the pillars of 340B is getting drugs to uninsured and indigent patients. Great example of this is Humalog. You all have diabetic patients that can't afford their drugs, and they end up in your ER or at your clinics with ongoing issues because they're not able to afford their drugs. Lantus is $300+. Humalog is $130 to $150. Very expensive prescriptions to have to take every month of your life. Under 340B, the price for Humalog and Lantus drops to under $20. So it becomes very easy for that patient to afford his drugs, stay on his doctor-prescribed regimen, and stop presenting at your clinics and your ER with ongoing issues. For the pharmacy, the rewards, they get an enhanced dispensing fee. We want your pharmacy to be more profitable. We want that pharmacist to be glad that you brought 340B to your community. He gets an enhanced dispensing fee. He's more profitable. Your patients are better taken care of because there's a quality pharmacy in your community on an ongoing basis. They also like it because it's a stabilized revenue stream for them. PBMs are constantly coming in trying to shave pharmacies down on their dispensing fees. A lot of pharmacies, if it wasn't for rebates, wouldn't be in business today. So 340B actually stabilizes that pharmacy's revenue stream.
Hey Adam, just again encourage folks to hit that raise your hand icon. I think it's a kind of a yellow looking button on your panel if you have any questions. And Adam, I don't know if you have the chat option available as well, but they may have some questions that come through that method as well. So
yeah, I don't see that up. I don't see anything there yet, Bill. I'm keeping an eye for the raised hands and nothing so far. And again, you know, we encourage you that if you just want to listen in and then follow up later with additional conversations, actually prefer that. I like a one-on-one conversation. It's much easier.
You bet.
So, Omnibus Mega Guidance. This came down 2 weeks ago, the Omnibus Mega Guidance we were expecting for 2 years. As I've been predicting for 2 years, the one area that got hit the hardest is dish facilities. Those large facilities that are buying up cancer practices and all kinds of practices to maximize their 340B revenue. So they really got hit the hardest in the Mega Guidance. FQHC's clinics got very little impact, which is the way it should be because they are really the safety net providers. Critical Access and Soul Community got a little bit from both sides. Changes that will be coming up, use of 340B drugs for discharge prescriptions looks like it will be prohibited. So if you've got an outpatient, or excuse me, an inpatient that's being discharged, those prescriptions written as an inpatient will be eliminated. Referral and follow-ups, this is one we hope gets reversed because in the critical access marketplace, this is a very worthwhile thing to have. That's your primary care physician referring a patient to a cardiac or a cancer doctor in a large city, and then coming back and filling those prescriptions at your contract pharmacy. Because you hold the primary care file, we believe that those should be allowed. HRSA is going after the DISH facilities here, trying to cut them off, but it's affecting the critical access marketplace. Physician-administered drugs. This is why split bill may become a lot less effective in a critical access or a sole community hospital. If you have an infusion clinic and you're infusing drugs for other physicians, in other words, a cancer doctor or some other type of doctor sends a patient to you and your physician administers a drug, at this point, because your physician is administering that drug, that's an eligible 340B transaction. We can save that revenue, or save that, get savings on that, but with the new changes, we'll lose the ability to do that. Again, going after the DISH facilities, and it's impacting the critical access. New rules will govern the use of 340B drugs for Medicaid managed care. Up until now, MCOs have been in kind of a gray area. They're trying to lighten that up and make it a black area. So MCOs will be changing under 340B. There will be new exceptions to the GPO prohibition. If you're a sole community or a critical access, that doesn't matter to you. But if you're a DISH, GPO prohibitions are going to become more restrictive. Be new requirements related to record retention. So as you can see, that there's changes coming down in 340B. Audits are one of the biggest things that hospitals are worried about in 340B. 4 years ago, we didn't worry about them, neither did the hospitals, because there were none. In the last 4 years, they have ramped it up dramatically. We've had 3 this year alone with our entities. Audits are random. They pick you out of a hat and you get an audit. What they're going to look for in those audits is eligibility status. For a critical access hospital, that's a very simple thing. You usually have one parent site, maybe 1 or 2 child sites, if even. So your eligibility is very easy to maintain, but making sure it's correct is key, because one small mistake in your eligibility status can get you shut down on the program for 3 to 6 months. Policies and procedures, that's one of the things they make sure, or they check extremely closely in an inventory. I just got done with one about a month ago, and we spent a lot of time going through the hospital's policies and procedures. You want to be very careful here about using stock or boilerplate policies and procedures. HRSA does not like that. They want your policies and procedures to be customized to your facility, and that's not so easy to do. It's one of the things that we strive to make sure that all of our clients have customized P&Ps for their program, so it reflects the hospital's management of the program, not some boilerplate piece they picked up off the internet. Diversion, that's giving a 340B eligible prescription to a non-340B patient. If set up correctly, it's relatively easy to avoid this. Duplicate discounts are the biggest violation in 340B. That is giving a 340B discount to a Medicaid patient. Happens more often than you'd like, and mostly because the states do not have a good handle on how to disseminate their Medicaid information. So we have actually come up with unique ways to audit your program to catch those duplicate discounts and get them reversed out prior to an audit. We do minimum of 2 mock HRSA audits on our clients per year, and one of the main things we do is try and find different ways to catch those duplicate discounts, and we find them in virtually every audit we do. The administrators do their best, but because of the poor information coming out of Medicaid, sometimes it's hard to catch all of those duplicate discounts. But the auditors will. 340B enrollment. The next enrollment date for facilities is October 1st through 15th. If you register your hospital on October 1st through 15th, you will have an eligibility date of January 1st. That means in January 1st, you can register your pharmacies, and then your pharmacies will have an eligibility date of April 1st. So if we were to register a hospital coming up in October, we would be able to have them live April 1st, providing we got all the IT interfaces done in the meantime. Why ACI? Got to throw in a little bit of advertisement for ACI here. We're vendor neutral. We work with all the major TPAs, Sentry, SunRx, Macrohelix, you name it. We know who they are. We know their pricing. We know their pros, their cons, and their vulnerabilities. They all have problems, and they all have positive things too. Each one is unique. We maximize your 340B savings. We'll have your program up and running in the shortest amount of time possible. Depending on your EMR or your hospital's IT capabilities, these programs can be very difficult. We've often seen hospitals taking in excess of a year to set up their 340B programs. So we try and cut that down as much as possible. We've been through them many times, so we can understand the pitfalls and what to watch out for. We make sure contract pharmacy network is beneficial for both you and your pharmacies. And I can't emphasize this enough. If you're working with an independent in your town or a small regional chain, 340B can be very difficult for them. They need help with it. It can't just be set up and fire and forget type program. We keep you up to date on the 340B changes. They are changing rapidly. So if you have any questions, I do have one other thing I want to touch on. Let me pull it up here. Bill, now would be a good time if you want to say anything while I pull this up.
Well, I did have a question. You had mentioned you've gone through a few of these audits, and folks hear audit and they understandably get concerned. What kind of results did you see as those audits in terms of any slaps of the wrist or anything of that nature? What was the end result?
Well, we've been through 4 audits. All of them have been extremely clean. And if you know what to look for and what to prep for, the audits go very smoothly. If you don't, the HRSA auditor can really start digging. It's kind of like going to court. You never answer a question that you haven't been asked, and you keep your answers short. We've seen a lot of mistakes made by entities trying to be very forthcoming. They end up digging themselves into a hole. We had one finding on one hospital where a doctor, let me see, a doctor was married. His wife went to a different doctor for a primary care physician. He prescribed her a prescription for a UTI. It wasn't working, so her husband prescribed her something else. It was caught on the 340B program because she was a patient. The HRSA auditor didn't accept it as a referral, so because a husband gave a prescription to his wife, we had a case of diversion in that one case. Believe me, that is kind of ludicrous. Even the auditor felt bad about having to report it. It's been kind of a joke a couple times, but that is the only finding we've had in 4 different audits across the country.
Like a real one-off. So when an audit comes up, what's ACI's role with their clients?
Well, we actually coach you on the audit. So if you get an audit notice, we come in and let you know what's going to be expected, what's going to happen, what are they going to ask. We review your P&Ps to make sure that they're up to date and correct and personalized. Then when the request for data comes down, what they'll do is ask you for 6 months worth of data out of your program. The TPA provides that, but then we comb that for any potential problems. And if you're a client of ours, we've actually audited it a couple of times already during that period of time. So in most cases, you're pretty well prepared going in. But just even in the last audit we were in, we found a major mistake that the TPA had made just prior to the audit. We were able to make it not quite so relevant in the audit, and the HRSA auditor overlooked it. So we dodged a bullet there. So I mean, there's always mistakes, but keeping those audits up to date, or keep the P&Ps up to date, and prepping for an audit is huge. All right.
Very good.
Bill, do you see a little screen that says TPA pricing?
Yes.
All right, good. This is an actual case that went through with one of our clients and priced things out. The third-party administrator, whoever it might be, I mean, we just listed a bunch of them here, but TPA 1, 2, 3, or 4, I'm keeping their names confidential to protect them. High volume pharmacy. This was a Walmart with 240,000 claims going through it a year, and the revenue coming from this one Walmart for this covered entity was $552,000. Low volume pharmacy, 34,000 total claims going through that pharmacy, not all ours. These are not all our clients' claims, just the total claims going through. And in this one, the revenue was $340,000. Oops, I missed a zero there. My apologies. $340,000. TPA number 1 charges a flat fee. The problem with this TPA is they don't do split bills, so they don't work in a lot of cases. But I apologize. This is a brand new slide. Jonathan's got a little bit of work to do on it. There's another zero that's meant to be there, so it should be 18,000, or he just couldn't read my writing. 18,000 on both of those. TPA number 2 for those same pharmacies would have charged 27,000 for this one, 30 for this one. TPA 3 would have charged 53,000 for this one, and because of the way this one worked out, it would have cost in excess of 137,000 for those TPA services. TPA 4 would have charged 62,000 for this pharmacy, but only 8,000 for this one. So as you can see, and these are all realistic numbers, except for that one, which needs another zero. These are all realistic numbers based on high volume versus low volume pharmacies. If you choose the wrong TPA, you can end up paying way more than you need to, and understanding the environment, which TPAs, which work best with which pharmacies, which one struggles, which ones cannot contract with certain pharmacies, is a big part of what ACI brings to the game. We understand the interactions between all the major TPAs. This is another good example. This is a spreadsheet that I look at on a daily basis, and what we're looking for here is, here's the revenue to the hospital. Not bad. That's 1 month's revenue to a hospital. Covered entity benefit on that, or revenue coming into the pharmacy, covered entity or the hospital benefit, 14,000. Not bad. Should be pretty happy. Our brand generic mix, 14%. That means nothing to you. That means a lot to me. That's a little below average. Paid claims. We had 8,900 claims go through that pharmacy. But here's what bothered me. Only 426 of them were captured for my client, my covered entity, my hospital. That was 5.6%. The TPA at this point thought they were doing a fine job, because for them these numbers looked good. But for us, we know that in a rural environment, and this particular facility, very rural hospital, actually in Oklahoma, we knew that they should have been doing 15,000 claims, or excuse me, 1,500 claims a month. Their percentage rate should have been in excess of 20%. And what that means to the hospital is they would have collected 110,000 and their revenue would have been 57,000. So it's understanding what you're looking at for the environment that you're working in is huge. I mean, as far as the TPA was concerned, and it doesn't matter, the TPA didn't do a bad job here. They were sorting the claims correctly. It was actually an EMR problem coming out of the hospital. We knew this number was wrong. We knew this number was wrong. We knew where that hospital should be. These corrections have been made, and the hospital's revenue has quadrupled. This is part of what ACI brings to the 340B program, is understanding how this program should work, how it should perform, and maximizing those benefits. That's it for me, Bill, unless you want to see anything else.
No, I mean, you maybe give just a little explanation of how ACI is compensated. I mean, in my experience in referring over a dozen hospitals to you folks, all of the clients are happy with your services, and to me, you do a heck of a lot of work without getting paid, basically because you're on a contract, performance-based contract. Can you kind of elaborate on that a little bit?
Sure. We, as Bill said, we work on a performance-based contract. We don't get paid if you're not making money. So we bill you a percentage of your net revenue. After your 340B costs, we bill you, because we track it on a monthly basis, we bill you 10% of your net revenue at the end of the month. If you made a lot of money, well, we bill you significantly, but we believe we make that worthwhile. If you're a small hospital, those bigger hospitals offset those fees for us. So we just want to be consistent with everybody. We bill 10% of your net revenue after the program's up and running. If it takes us 6 months to get the program up and running, we don't get paid for 6 months. We've actually got multiple hospitals, their programs have been up and running for 3, 5, 6 months. We're just not happy. Matter of fact, that example I just showed you, we haven't started billing that hospital yet because we don't feel like his revenue is where it needs to be. Until it is, we don't want to get paid, until the program is running correctly. So we work on a performance basis. Very easy to get along with. Our contract has been reviewed by many hospitals. Very rarely do we get any red lines or pushbacks on it. It's a very simple, short agreement.
Very good. Like, unless there are any questions, I guess we can wrap up. We will definitely follow up within the next day or two. I will go ahead and send an email to those who joined the conversation today. And I'll include Adam's contact information and my contact information, and hopefully this was educational. Maybe it stirred up a couple of questions or thoughts that you might want to have offline. So if you want to have a 5-minute conversation, or you want to have a 45-minute conversation where you maybe need to get some other folks within your organization on the phone, we're happy to help in any way we possibly can. So with that, Adam, I think we'll conclude unless there's anything else to be said.
Nope. Feel free to reach out. As I said, as Bill said, he'll give you my contact information, email or a phone call. I've actually had 2 phone call requests while I've been on this webinar. We'll be glad to sit down and talk to you. But thank you very much for joining us. I hope to talk to you soon.
Thanks, folks.